and welcome to today's edition of Patcast. Today, we are happy to welcome none other than Dr. Raul Gonzalez, who is an assistant professor of pathology at Beth Israel Deaconess Medical Center at Harvard. And today, he is going to discuss on a very interesting topic, which he has named as mesenchymal madness in the GI tract. As always, please feel free to post your questions or comments on our Facebook chat window or YouTube windows, and Dr. Gonzalez will be more than happy to answer those questions at the end of the session. So without much ado, over to Dr. Gonzalez. Thank you.
Good morning, and thank you for the introduction. Sorry we're getting started a little bit late. Since Halloween is next week, I thought I'd inject a little bit of that flavor into this with the clip art and the title, Mesenchymal Madness in the GI Tract. I've got 30-something cases to go through, and there's a little bit of information about each diagnosis in the PowerPoint. Since these are mostly teaching recuts, I'm only going to have H&E, no immunostains, but I will talk about the immunostains you can use to confirm your diagnosis and rule out any differential diagnostic possibilities. And then if you have a question, hopefully they can, if you post it on the places he mentioned, hopefully they can get that to me. I'll also be monitoring my Twitter feed, or if you post to Twitter and use the hashtag Mesenchymal Madness, as it says at the bottom there, I'll check that hashtag after the end of the slide session, and I will answer any questions that are there. So without further ado, let's get started. Minimal information, clinical info for most of these. We're going to start with case 1, which is an esophagus mass. We're just going to go top to bottom down the GI tract. There's not as much mesenchymal stuff in the esophagus as in some other spots in the GI tract, but this is one of the most common things you're going to see if you're dealing with mesenchymal things in the esophagus. At low power, you can kind of make out that the squamous epithelium is here, and it looks a little funny. There's little hyperplastic phenomenon here. It's kind of going down at a first glance, maybe even looks invasive, but if you go in on higher power, you can easily notice that there's something else filling the space just underneath the squamous epithelium, and it is this sheeting proliferation of bland mesenchymal cells, very pink, prominent cytoplasm, kind of somewhat nondescript nuclei, not hyperchromatic, not ugly, no mitotic figures, looks very bland overall. And of course, this is a granular cell tumor, which is going to be the most common mesenchymal little thing you encounter in the GI tract, in the esophagus. Benign, not really of any clinical concern. In fact, the main problem with them is that sometimes you get this pseudoepitheliomatous hyperplasia overlying them. And let's say you get a suboptimal sample. I'm going to try to position the slide. Let's say all you get on a biopsy looks something like this, and it's hard to really make out the granular cell tumor because you just barely get into it, and you're mostly just seeing some funny squamous change. You might mistake the lesion for a squamous cell carcinoma or dysplasia. Granular cell tumors are benign. They're not typically considered syndromic. You can confirm the diagnosis by doing an immunostain for S100 and CD68. And if you don't want to bother your immunolab, you can also do a PASD stain. That'll be positive as well. So the diagnosis is granular cell tumor of the esophagus for case number 1. Case number 2, another esophagus mass. Here we go. At low power actually looks a little similar. We've got the squamous epithelium, and then we've got this thing here. And in many ways, it looks similar to the granular cell tumor that we just took a look at. Rounded granular cells, abundant pink cytoplasm. But here you've actually got some nuclear atypia. Some of the nuclei are larger, hyperchromatic, smudgier, a little bit streaming. There, that guy looks pretty weird. What's he up to? This is actually just an atypical granular cell tumor of the esophagus. The vast majority of these lesions of granular cell tumors that you encounter in the GI tract and basically in general are going to be extremely bland, extremely benign, no concerning features. But on rare occasion, these can recur or metastasize. It's a little hard to correlate the potential behavior with the histology, but if you see atypical features like this, these nuclei, you might be a little bit more worried. You will notice there's no necrosis, no mitoses, no other concerning features. And again, the most likely outcome of this lesion is nothing, but there's a tiny chance that this can recur or metastasize. And I'm mostly just showing this to let you know that there is such a thing as an atypical granular cell tumor of the esophagus, but this is going to be a minority of your cases. Sticking around in the upper tract, this next case is a gastroesophageal junction mass. So here we're at the GE junction. Here's the esophagus, here's the cardia, and then there was no mass in this particular location. This was actually taken out from a patient who had adenocarcinoma of the esophagus. And what I'm trying to show here is, unfortunately, a wimpy example of a lesion that is quite rare and I've never seen a blatant example of. But you may notice at low power already that the muscularis propria looks like it's forming little nodules here and there. There's 3 in this field. Maybe if you hallucinate, there's a couple in other areas. But if we go on higher power, you can tell that these discrete nodules are have the same composition as the background smooth muscle of the muscularis propria. So that makes these little leiomyomas, which then, since we've got a bunch of them and they're studying the muscularis propria of the esophagus, we would go with the term leiomyomatosis. Again, this is not a great example, but it's pretty rare. More florid examples can occur. These can grow to be, a centimeter, several centimeters in size. They can cause symptoms. This, of course, was, as I mentioned, an incidental finding. So this is an example of leiomyomatosis of the esophagus. As I said, it's rare. It is more common in children, and it does have a syndromic link to Alport syndrome. So if you see this on your boards, or if you encounter it in practice and it's a pediatric patient, that is something that you might want to suggest in your sign-out report. Still in the esophagus, although we're almost done, this next case, let me mute my phone here. Sorry about that. This is a large esophagus mass, let's say 15 to 20 centimeters, extending down into the esophageal lumen. Hold on one second. I'm sorry, can you call back in about 1 hour? Thank you, bye. Sorry about that. So large esophageal mass, 15 to 20 centimeters. Let's say it's kind of polypoid shape and extending down into the lumen of the esophagus. And we can tell we're in the esophagus. There's a little bit of squamous epithelium, but then we have this large mesenchymal mass. You can at low power see that there's a preponderance of fat, or at least a good amount of it, more over on this section. And there's some sort of spindle cell proliferation in the background. If we look closer, we can see that it's fairly bland. There's some inflammatory cells, mast cells, and if we look for a while, there are occasional atypical cells. Of course, I'm not finding them right at this second, but they are here. So for a long time, this was a lesion known as giant fibrovascular polyp of the esophagus. But in the past couple years, a group at Mayo Clinic realized, hey, these look kind of funny. These look a little atypical. There's a lot of fat. Let's do MDM2 FISH on all of these. And it turned out that they were all positive. So these are all, in fact, depending on how you want to phrase it, atypical lipomatous tumors or well-differentiated liposarcoma. This particular case was sent to me by Rondell Graham, who was the lead author on that project. Again, this is rare enough. I've never seen a case myself. But if you get a large mass protruding out into the lumen of the esophagus and you think, wow, this looks like a giant fibrovascular polyp, do a bit more testing, because it is most likely, in fact, a well-differentiated liposarcoma. These patients tend to do well overall, especially if you can get all the way around the lesion. Rarely these can actually de-differentiate. Those patients will do more poorly, unsurprisingly. You might have local recurrence, you might have metastasis, and you might have death from tumor. So well-differentiated liposarcoma of the esophagus. Do MDM2 FISH to confirm this diagnosis. Moving on into the stomach, which has a lot more going on mesenchymal-wise than the esophagus. We are going to start with this. Here we are in the stomach, we're in the body, and we have this large, rounded spindle cell mass. Very cellular at low power. You can tell how dense it is. If we go on higher power, nice and spindly, nice fascicles, well formed, fairly bland, although it is quite hypercellular. There's not a lot in the way of atypia. Mitoses appear rare. There's no necrosis. There's this area of hemorrhage. This was actually the biopsy site. These often get biopsied beforehand. Don't confuse that with intrinsic necrosis of the lesion. And if we look around, there's a characteristic feature that's always helpful on H&E. We can see these little perinuclear vacuoles kind of indenting the nuclei in many, but not all of these spindle cells. This is actually an artifact of fixation. So if you got this on frozen section, you would not see that because it's fresh tissue. So this is a spindle cell neoplasm of the stomach. You're going to need to do immunostains on this, but the most common spindle cell lesion in the stomach and in most of the GI tract is going to be gastrointestinal stromal tumor, or GIST. Those are positive for c-KIT and DOG1, which this is. So this is in fact a GIST of the stomach. This example is a little unusual. It's kind of fun. It's got these entrapped glands, maybe a little bit of gastritis cystica profunda or something. This is not something you see commonly, but I think it looks kind of neat. Has no bearing on the outcome of the lesion. When you are doing risk stratification for GISTs, only three things matter: the location, namely stomach in this case, the size, and the mitotic rate. There's a chart that was put together by authors at the AFIP who looked at a whole lot of GISTs. They did an amazing job. So for GISTs in common locations, the stomach, the small bowel, the rectum, you can pull up this chart. It's available in major textbooks and the CAP template, other locations, easy to find, freely available. You can see the likelihood of these tumors recurring. If they do have a high risk of progression for disease, there is treatment. You can give Gleevec. It targets the KIT mutation that these tumors tend to have. A small number of them might also have PDGFRA mutations. I've got plenty more where these came from, so that's just the first case of GIST that I'm going to show you. Let's move on to the next stomach mass. You can see that we're all still in the body of the stomach, and at low power, this lesion has lymphoid follicles along the periphery of it. If we go in, it's spindle, but it's very palisaded. You can see that the nuclei are lining up very nicely, these little packets of the cells. Still very spindly, very fasciculated, prominent vasculature here. So let's do our panel of immunostains. And this tumor is also positive for c-KIT and DOG1. So if you were thinking this was something else, it actually is another GIST of the stomach. These can mimic other mesenchymal lesions, but your differential needs to be number 1, number 2, number 3 GIST, and then worrying about all the other things. So if you subtract out the features I pointed out, the prominent vessels, which might just be entrapped, and the palisading, this looks basically exactly like the previous lesion I showed you, maybe a little less cellular, and the inflammation here is a bit of a red herring, but this is another GIST of the stomach, not a schwannoma, despite the palisading and the prominent vasculature, and in the stomach, the peripheral lymphoid aggregate. Here is another stomach mass in a younger patient, let's say 20, 25. That counts as young for me these days at least. And at low power, you can see that this is predominantly this one nodule here, but there's also areas where it's kind of multinodular, a bit maybe more plexiform, fusiform out here. Not one nice discrete round mass the way those last two GISTs were. We go on higher power. This is a little more epithelioid. it still has this kind of vague sense of spindliness about it, but the nuclei are more rounded. If you were to do c-kit and dog1 on this lesion, which of course we should always do on these stomach masses because GIST is the most common diagnosis, this would also be c-kit and dog1 positive. However, if you did mutational analysis, it would not show a c-kit or a dog1 mutation. The old term for these is wild-type GIST, but we now know that this particular subtype of GIST tends to harbor abnormalities in one of these succinate dehydrogenase genes. And if we were to do SDHB immunohistochemistry, which I don't think most labs have available, mine does not, but you interpret those the same way you do MMR stains in the colon. Normal unremarkable staining is retention of the nuclear protein. But in this lesion, the SDHB protein would not be expressed. It would be absent and therefore abnormal. And this is what we see in these so-called wild type or pediatric type GISTs, which are more common in younger patients, pediatrics to young adulthood. 99.9% of them in the stomach. There's, I think, one case report in the duodenum, things like that, but these essentially only occur in the stomach. A couple interesting facts about these lesions. I put a lot of text on this because I think these are really cool. I've mentioned some of this. Unlike most GISTs in other locations, these can actually metastasize to lymph nodes. That's so rare overall that the AJCC staging for GIST does not have a PNX category. If you don't get any lymph nodes along with your resection for a GIST in the stomach, you can, or for a GIST anywhere, you can just say PN0 because the likelihood of there being nodal disease is practically nil except in this subtype. Additionally, the traditional risk stratification I talked about, size and mitotic rate, doesn't really tell you how these are going to behave, but overall these patients do have a good prognosis. Maybe it's because they're younger, maybe it's intrinsically something about the tumor, but fortunately patients do well with these tumors. And finally, going along with the SDH abnormalities, patients with these tumors may have carne triad or carne stratitis syndrome. So unlike many of the other things I'll be showing today, this actually does have syndromic implications. Moving on, yet another stomach mass. And rather than a resection, this is a core biopsy. They saw something submucosal, and with their good strong arm, they tried to take a biopsy. And as unfortunately often happens, it's mostly blood, but we actually do get a little bit of lesional tissue here. And we can see this is very epithelioid, very rhabdoid looking actually, or at least to me, there's this fat belly of bright pink cytoplasm. Here you can see, I think it's maybe best right here. So there's a wide differential diagnosis for this. When I got this, I threw about 10 immunostains on it. But if you've been paying attention, you might be able to guess that this was also positive for c-kit and dog1, making this yet another GIST of the stomach. And again, I am beating this dead horse because this is the dead horse you're going to encounter far and away the most common in the stomach. You absolutely have to rule out other possibilities, leiomyosarcoma, even rhabdomyosarcoma with that look. Various other mesenchymal things, but always do your c-kit and your dog1 because most of the time you're going to end up having a GIST, which was the case for this patient. All right, sticking around in the stomach, a lot of cases because a lot of mesenchymal stuff pops up there. And this, much like the case from a couple slides ago, also has a prominent lymphoid cuff. We have a very nice look at this lesion. And if we go in, it is also bland and spindly. Fasciculation, not quite as prominent, at least in this case, as in some of those GISTs I was showing you. We're not seeing great nuclear palisading, maybe very subtle here and there, very focal, but not extremely prominent. You're not also seeing striking hyper and hypocellular areas. They might be somewhat a little busier here, a little less busy out here. And the vasculature is also not really jumping out at us. But you do see focal nuclear atypia. That's not the best example. Let's look around. There's a good one. There's a funny looking cell. There's a couple more here. Little large, slightly hyperchromatic, not extremely ugly, no necrosis, no mitoses, and we do have this lymphoid cuff here. So this finally is negative for c-KIT in dog 1. This is not another GIST, but this is nicely positive for S100 because this is a schwannoma of the stomach. And these actually look a little bit different than their soft tissue counterparts. There was a nice series from Hopkins several years ago looking at these. Compared to soft tissue schwannomas, you don't tend to see prominent nuclear palisading. You don't tend to see prominent highlighted vasculature, but you do usually see the lymphoid cuff greater than 9% of cases. And of course, it will be S100 positive, which is going to confirm your diagnosis of a schwannoma in the stomach. And one other thing to point out, that these do not have a capsule in the GI tract, unlike their soft tissue counterparts, but they're close enough and they're S100 positive, so we still call them schwannoma. Oops. Next case, formatting got a little funny there, so I guess, am I trying to say this is a tiny stomach mass? No, this is not a tiny stomach mass. This is just PowerPoint getting in on the madness. Here we have another spindle cell neoplasm. This one's much less well defined. You know, it's trickling out into the wall a bit more insidiously, hard to get a good sense of where the tumor stops and the wall begins. We go on a higher power, very strikingly fasciculated. There's some nuclear atypia. We can already tell there's prominent mitoses. The cells are enlarged, and already at low power, I can see some mitoses. There's one, nothing I've really shown you has had prominent mitotic activity so far. Here's another one. I am not great at finding mitoses, and yet they're definitely popping up in this lesion. There's another one, maybe, nah, that one's not great. Won't belabor the point. Here's another one. This ended up having a ton of mitoses. There are some fields where there were 3 or 4 in one high power field. So this definitely looks malignant. This looks like a worse actor than the other things we've been seeing. Always got to do GIST. GIST can be mitotically active, can look very atypical, can in fact have necrosis, but this was negative for c-KIT in dog 1, also negative for schwannoma, but positive for smooth muscle actin and Desmond. So we've moved into a smooth muscle tumor of the GI tract, and with this degree of atypia and the mitoses pretty much everywhere, I think it's safe to say that this is a leiomyosarcoma of the stomach. These are pretty rare. Smooth muscle tumors of the GI tract are fairly common overall, but they typically occur in the muscularis mucosae. They're small and superficial and don't mean much. Smooth muscle lesions of the muscularis propria are much less common and much more likely to be malignant. I was fortunate to be part of a large multi-institutional study that gathered as many of these muscularis propria smooth muscle lesions as we could find. We ended up with several hundred, and the manuscripts being worked on. There was a platform at USCAP earlier this year, and the group found that roughly criteria for malignant behavior, namely leiomyosarcoma versus leiomyoma, was 4 mitoses per 10 high power fields, atypia, and necrosis. So nothing terribly surprising, but it's nice to have a discrete cutoff or a number to aim for, namely 4 per 10. And again, this thing had 4 per 1 in some location, in some fields, so definitely leiomyosarcoma of the stomach. All right, back to normal formatting. We have another stomach mass, and this is also really ugly looking. This is clearly sheeting out, doing whatever it wants. We've got a little bit of normal mucosa here. Let's go in higher power. Not really spindled at all. Epithelioid, mitotic activity, large NC ratio. Occasionally these giant cell looking things. It's just barely on the field. Let me move it here. There you can see more toward the center now. We have occasional giant cells or clumps of cells. This is also pretty malignant looking. There's little areas of maybe cell death or necrosis. Doesn't look like much of what we've seen before, though of course you're going to have to throw a whole lot of stains on it. This is going to actually be positive for S100 and SOX10, but it's also going to be positive for neuroendocrine markers, CD56 most commonly, but synaptophysin and chromogranin can be positive as well. And if you are thinking about what the diagnosis is and you send off FISH for an EWSR1 translocation, it's actually going to come back positive. So if you got something like this with that translocation and a similar immunoprofile in the soft tissue, you would call it clear cell sarcoma of soft parts. So the old term for this was clear cell sarcoma-like tumor of the GI tract, but with more cases published, the current term that people are using is gastrointestinal neuroectodermal tumor of the stomach. These are rare. I've seen 1 or 2 cases, and both were found by looking through the archives at my institution. Rare, poor prognosis, has that gene rearrangement, which can help you confirm that it's not a melanoma with the S100 and SOX10 positivity, although synapto would, of course, be weird for a melanoma, but only about half of these are going to end up having neuroendocrine marker positivity. So that is a helpful pairing of immunostains. So that's GNET of the stomach. Here we're going on to another one, and this was a little stomach polyp. This was not deeper in the wall, so they were able to pluck this one right out. And you can see that there's definitely something going on in the submucosa here, and actually maybe percolating a little bit into and through the muscularis mucosae. Let's go in on higher power. There is a spindle cell proliferation here, but it's pretty bland. It's kind of sparse. And another thing that jumps out at you once you're looking at this for a little bit is the eosinophils. They can be more prominent. This is not the most blatant example, but if you go down higher power, there's definitely several eosinophils running through this. And if you look around, you can also tell that the spindle cell proliferation in the background is focally doing some onion skin whirling around these small capillaries in the mucosa. So let's get our C-kit and our dog 1 just in case they're negative. But we really think this might be a GIST. Let's try another GIST marker, CD34, which is positive in GISTs. That's also going to be positive in this little polyp. And let's say you send off for mutational analysis and you find a PDGFR mutation. Do not be fooled by that mutation plus the CD34 positivity, because this is not a GIST. This is actually an inflammatory fibroid polyp of the stomach. Less common than GIST, usually more superficially located than GIST. I've seen them throughout the wall of the GI tract, but they're most commonly superficial. I mean, polyp is in the name, which makes sense. Characteristic histology, CD34 positivity, the other GIST markers will be negative. Cute little thing when you come across it. Sticking around in the stomach, case, trying to do the, well, you got spoiled. That's what I get for trying to control the keyboard with my left hand while I do the microscope with my right. But anyway, pretend you didn't see the answer. Here's a stomach mass, and this seems more deep than some of the other masses. There's no mucosa here. We're down and kind of in or beneath the muscularis propria. And at low power, this looks sort of vasculature. You can see there's these spaces that it's forming. Going on higher power, still looks vasculature, still looks vascular. There's a lot of vasculature in it as well, plenty of blood well contained within these vascular channels, and the cells are actually very epithelioid, rounded, very benign. However, there's no mitotic activity, there's no necrosis. You can put stains on this, and this actually, as you already saw from the slide I accidentally spoiled for you, is a glomus tumor of the stomach. Glomus tumor is rare throughout the GI tract in general, but if it's going to pop up anywhere, the most common location by far is in the stomach. I have not seen it elsewhere in the GI tract. It is a benign process. Some of them can stain for vascular markers, in particular CD34. But the marker that's most commonly positive and that's really going to help you alongside the H&E appearance is a smooth muscle actin immunostain. This is another stomach lesion, although this was incidental. This patient had morbid obesity and underwent a sleeve gastrectomy. They saw a little nodule along the wall, which we're going to see right here. And this is also spindly in a sense, but it's very densely collagenous or fibrous. You can pick out a hint of a spindle cell or almost epithelial proliferation in the background, but the most striking thing absolutely is the dense fibrosis. And if you look around, you might see calcification. You don't always catch it, but there's a nice drop of calcium there. There's another small one right here. So this is calcifying, and it's fibrous, and it's a tumor. So let's call this a calcifying fibrous tumor. Also sometimes known as calcifying fibrous pseudotumor, although it is in fact a mass-forming lesion. So tumor is accurate, even though it is non-neoplastic. It's benign, and it's not going to cause any harm. The only real trick with these is that they don't always have calcification present. It could be a sampling issue. It could just be the tumor. So that can make them a little harder to diagnose. If you want to do immunostains, there may be some CD34 positivity, but really your tip-off is going to be the dense calcification throughout the mass. Almost done on the stomach. I've got 2 more stomach masses here, and these are both rare and sufficiently rare that these slides are both gifts to me. But this is a stomach mass that looks plexiform. You remember maybe a little bit like that pediatric type GIST, although this is very, very discrete. There's relatively speaking a mile between each of these little tendrils. So you might be thinking of plexiform things, plexiform neurofibroma, things like that. This is very bland. This is going to be negative for neural markers, so we can go ahead and toss out plexiform neurofibroma. But it has a spindle cell proliferation with a fibromyxoid background, very thin vasculature. For the most part, there's also some thicker walled vessels. This clearly looks benign overall. The only thing that even looks a little funny is kind of how infiltrative it is, although it's sort of large pushing infiltration. Here's a larger nodule of it here. This tumor has gone by a couple different names. It is rare. As I've said, there's a couple dozen cases in the literature. It almost always occurs in the antrum of the stomach. And the term that I like for these, because it is the shortest and the easiest to remember, is plexiform fibromyxoma of the stomach. This was a gift to me from Dr. Cheryl Coffin, who was at Vanderbilt while I was doing my training there. And one interesting thing about these tumors, they are indeed neoplastic. They have a MALAT1 GLI fusion. I don't know if I'm pronouncing these genes right. I just see them written, but that's what I'm going to call it. So if you wanted to confirm the diagnosis, immunostains are not going to be extremely helpful, but that fusion is fairly characteristic for this lesion with this histology. However, it is not the only stomach tumor with this translocation. This next one also has it. This is another stomach mass, and this is actually another gift from Rondell Graham at Mayo, who helped do some characterization of these lesions. This is another kind of infiltrative mass. This is in the wall of the stomach. I promise we're in the stomach, even though it's hemorrhagic and you can't really make out the mucosa anymore. And it looks biphasic at low power. There's this area here, there's this area here. Let's take a look at both of them. This area looks more epithelioid, very nested, almost kind of neuroendocrine. You've got what almost looks like salt and pepper chromatin. It's very packeted. It's not quite as purplish as those tend to be. It looks well behaved though. No striking atypia, no necrosis. This is the epithelioid component, maybe very focally, a little spindly. But if you want spindly, let's go over to the other component, which looks very different overall. Very spindle. This is kind of loose, primitive mesenchyme. Although overall it's fairly bland as well, no necrosis, no mitoses. So we have a stomach mass with a biphasic appearance, and this also has that MALAT1 GLI fusion. And this is a gastroblastoma of the stomach. There's, I don't know, 10, 15 cases I've seen in the literature. There's a rare reports of similar tumors in the duodenum, but at least those we can call duodenoblastoma. Have not seen one of those. Despite the fact that you might think this is a bad actor, it's a blastoma, it's primitive. It looks, doesn't look terribly ugly, although there was all that ulceration overlying it. These patients do have a good prognosis. So if you ever happen to see one, and I certainly don't anticipate having one naturally cross my desk during my career, you can at least say that the patient is likely to do well. All right, finally, we've escaped the stomach and we're moving farther down the bowels into the small intestine. Here we go, small intestine. Here's our mesenchymal mass. This looks very strikingly epithelioid, although there's not a lot of atypia. There's not prominent mitoses. Most of these funny-looking squiggles are lymphocytes. So this was a nice example of an epithelioid gist. We're back on the gist train, c-KIT and DOG1 positive. This is just to remind you that you always want to have gist at the top of your differential. And this is a pretty classic epithelioid gist. I did have that epithelioid rhabdoid looking gist, and the wild type pediatric gist was a little epithelioid, but this is a more classic example. Epithelioid features do not factor into the risk stratification. Again, it's just going to be size and mitotic count. So there is a gist of the small bowel. This next case is another small bowel mass, and I'll spoil it for you. This is going to be another gist. This, again, has necrosis where they biopsied the lesion. And at low power, you might think, oh, it's very spindly, but it's very bland. This looks a little bit like one of the stomach gists from earlier, so it's probably got a low mitotic count. I don't need to bother with it. Unfortunately, you do need to bother with it because if you actually go in on high power, there's a mitotic figure. There's one up here. There's one right there. This is a very mitotically active gist. This fooled me at low power, but there's a mitosis. Up there is a mitosis. You know, I could point out mitoses all day, but this ended up having something like 20, 25 per 10 high power fields. So you do in fact, 20 high power fields. So you do in fact need to always count mitotic figures and not just assume what the count is going to be. I will point out a lot of the older literature on gists, especially counting mitoses, used smaller fields of vision, which is where the 50 high power fields come from. Double check your microscope, double check what you're using, but a lot of modern microscopes, you probably only need to count to about 20 high power fields, which of course means you're going to get a smaller number overall. So don't spend too much time and overestimate the risk of a gist's progression because you didn't realize that you need to actually be counting in 5 square millimeters rather than just high power fields, because high power field is obviously not a truly standard unit of measurement. So actually you have to do the mitotic count. I don't enjoy it any more than probably most of you, but it is important for patients. Next case, small bowel masses. This is a patient who had multiple masses in their small bowel. We can see one there, kind of a little putative one there. Here's another one, here's another one. These are actually all gists, little bland spindle gists. c-KIT DOG1 positive, c-KIT PDGFRA mutation negative, but these actually, if you tested them, would have a mutation in NF1 because this is a patient with neurofibromatosis type 1, and these patients can actually get gists in the duodenum, multiples, if not hundreds. This patient had a couple hundred from the looks of it. They're often small and low risk, but they're certainly striking, and they could certainly cause obstruction if they even start to get big because there's so many of them. And this, depending on how you want to phrase it, would fall under wild type gist because it doesn't have the common mutations, but it does have an identifiable mutation in NF1 because the patient also has an NF1 mutation. So another fun thing that can happen with gists in the GI tract. Moving on, another fun tumor. This is a mass in the ampulla. This tumor almost always occurs in the ampulla. I've seen reports of it occurring elsewhere, but I have not happened to see one myself. And you can tell there's a couple different things going on throughout this lesion. You've got these areas with maybe more epithelioid cells, kind of loose. Then you've got this background, there's more epithelioid. There's also a spindly component kind of supporting it in the background. Looks bland overall. And then if you look around, you can actually see these very large, rounded, almost ganglion-looking cells. There's the other area has some better ones. There's one right here. Let me see if the green actually transmits a bit better, so go with that for the rest. So this is actually a triphasic neoplasm, an epithelioid component, a spindled component, and a ganglion cell appearing component. Almost always occurs in the ampulla, and this is known as a gangliocytic paraganglioma. A small number of them can metastasize. I've seen this in the liver once, but the vast majority of them are benign. Immunohistochemical stains can help you if you do neuroendocrine markers and S100. Each of those will be positive in 2 of the 3 components, as you can see there. Epithelioid and ganglion cells will pick up neuroendocrine, and the ganglion and spindle cells will be positive for S100. This can look quite variable. You can, since there's 3 components, it's not always a nice even split. In this case, actually had the most even split of the ones I could find. Sometimes it's 90 or 95% one of the 3 components. So anytime you get something in the duodenum or ampulla looks kind of funny, you're worried about a neuroendocrine or possibly a paraganglioma, think about this entity, do the stains, put the whole thing in and look closely, and you might be able to identify a small proportion of the other components, because again, you might not have a striking amount of most of the components. This patient, a younger patient, presented with GI bleeding, had multiple small bowel masses, and each of these tissue fragments is a mass. This is one of 2 vascular lesions I'm going to show you in the small bowel. Vascular lesions are not terribly common overall in the GI tract, but I dug out what I could to show you. At intermediate power, you can tell that these are very bland, but they're large, ectatic, thick-walled vessels. They look more like a malformation than they do a proliferation, at least to my eyes. Obviously, that distinction can be hard to make sometimes. But again, this patient had GI bleeding, had multiple AV malformations all throughout their body, including in the GI tract, because this patient has blue rubber bleb nevus syndrome. This case was from the small bowel, but the GI tract is actually a relatively common site for this relatively uncommon syndrome to manifest. Skin and soft tissues are number 1 and 2, but GI tract is number 3. So this is actually the second case of this that I've seen, so it can actually happen, and it's just something worth knowing about if you get multiple vascular lesions in the GI tract. Here is a small bowel polyp. At low power, looks pretty bland, looks kind of like granulation tissue. If you wanted to call this granulation tissue, that's perfectly fine, no harm, no foul. You might even be effectively correct. But if you go on a higher power, it looks a bit more lobulated, a little bit more organized than your typical granulation tissue. The endothelial lining for some of these vessel spaces is hobnailed. There's a little bit of background inflammation. Very focally, there might be some atypia, but it's not prominent. And if you did see it, it might be due to the fact that these can be ulcerated. This example is not particularly, there's a little bit of ulceration here. But this is uncommon in the GI tract. If you do see it, it's most commonly in the esophagus. But we called this a pyogenic granuloma of the small bowel. Other term, lobular capillary hemangioma, which is better because it's neither pyogenic nor a granuloma, but what are you going to do? Pretty uncommon overall. I worked with several people, including Lissandro Voltaggio at Hopkins, to put a series of these together, which we submitted as a fun little abstract to USCAP. So maybe you'll be seeing our series on this at USCAP next year, but if not, we'll have the manuscript out. These are small. Typically, they can get to be 1 or 2 centimeters. In rare instances, these are benign, usually unifocal, usually do not recur, most common in the esophagus. And if you call it granulation tissue, again, doesn't matter because these don't do anything. But it's always fun to be able to give something a more specific name if you think it warrants it. All right, moving on to the colon, which is going to have about as many cases as the stomach. Colon is a heavy hitter, and we're going to start with a bunch of little polyps. These are not uncommon, and they tend to cause consternation, even though most of them don't actually matter too much in terms of implications for the patient. So we have this mesenchymal proliferation that has more or less demolished the mucosa with the exception of the crypts, which are holding out quite nicely. Going on higher power, it's pretty bland. The cells are kind of spindly, although they're a little more rounded and kind of ovoid than, very thin and tapered. Kind of sheeting out, very, very vague fasciculation. No atypia, no necrosis, no mitosis, looks bland. If you did stains for this, it might be positive for EMA, it might be positive for Claudin-1, it might be positive for Glut-1, if you're really, doing all of these stains on this little polyp. The old term for these is benign fibroblastic polyp of the colon. But with that immunoprofile that I just mentioned, the current term is perineurioma of the colon. They by themselves don't mean anything. However, it's important to note that these can be present as a minor component underlying a hyperplastic polyp or a sessile serrated adenoma / polyp / lesion of the colon. So if you see one of these, just look around and double check that there's no serrated proliferation above it. I mentioned the immunostaining, but these are benign, so in a sense, it doesn't really matter what you call them. The next case I'm going to show is its most common mimic in the stomach, another colon polyp. I posted this on my Twitter, so several people already know the answer. This case is similar in that it's a spindly proliferation in the mucosa, submucosa pushing up into the mucosa of the colon. This one is a little more packeted, a little more myxoid, a little more wavy. Looks a bit more neural to my eye. Of course, I'm saying that because I know that this particular polyp is S100 positive, and it's negative for all of the markers that the perineurioma would stain for. So this is not a schwannoma. Those are usually deeper in the wall, would be a more rounded mass, have some of the features I showed you earlier. The term for this is Schwann cell hamartoma. Whether or not it's truly a hamartoma is debatable. I kind of like the term Schwann cell polyp, but either way, it doesn't really matter. Very rarely, these have been reported in syndromic patients, especially if there are multiple. You might think about Cowden syndrome, but if you just see one, it doesn't really matter. And you can confirm the diagnosis with an S100 stain. Yet another little colon polyp. This is probably some sort of cousin to the Schwann cell hamartoma. Looks kind of similar, but the cells are more epithelioid, kind of more nicely packeted. If you look around, there's actually these kind of cleared out nuclear pseudo-inclusions prominent in the lesion. This is also S100 positive, so if you wanted to call this like a baby epithelioid schwannoma or something like that, it's probably okay, but this presented as a polyp, and the long term for this that I always have to double check is mucosal benign epithelioid nerve sheath tumor. Also rare, also of no real consequence, no syndromic implications, not going to metastasize or anything. Positive for S100. If you did a CD34, there are supporting cells kind of embedded throughout the background of it that might stain positive, so don't mistake the lesion as having true CD34 positivity. Next up, another colon polyp, another one that gets people worked up. So I'm actually going to point out that this specimen had 2 colon polyps, and this up here is a TA, which actually is more important for this patient than the mesenchymal thing I'm going to focus on. We have this spindly thing expanding the lamina propria, and if we go in on higher power, spindly, Is it one of those things I just showed you? Oh, let's look over here. Oh, this is easy. Look at all these ganglion cells everywhere. This is very easy to diagnose as a ganglioneuroma. S100 positivity will confirm the diagnosis. If a patient just has a single ganglioneuroma, it means nothing. Again, that TA is going to mean more for them than a single ganglioneuroma. If they have multiple, let's say 2, 3, 5, a handful, they might have Cowden syndrome. S100 positive. So single doesn't mean anything. Multiple, maybe Cowden syndrome. But what if they have a confluent mass of ganglioneuroma-like tissue expanding the mucosa? There's ganglion cells in here, I promise. There's one. There's more if you look around. It's not just in the mucosa. It's in the wall here. Another ganglion cell. Down deep. Look at all this. You know, this is clearly more than just a little sporadic ganglioneuroma. This has been termed ganglioneuromatosis of the colon. This is not going to be sporadic. This is not going to be in patients with Cowden syndrome. This is going to be in patients with multiple endocrine neoplasia, MEN2B. This can obviously be symptomatic. This needs to be taken out. And if you did genetic analysis on the tumor, you might find that it has a RET mutation, which corresponds to the MEN2B syndrome. Excuse me. Back to more little polyps. Pay no attention to that lymphoid aggregate behind the curtain. I'm showing you a phenomenon that I actually talked about earlier. I mentioned that in the GI tract, leiomyomas are typically small incidental polyps that arise from the muscularis mucosae. This is one of them. This guy is intensely eosinophilic, probably the most pink-looking proliferation that I've shown today. Oops, bumped the slide. Looks vaguely spindled. You can make out the nuclei, but there's not a lot, or there's not really any atypia, necrosis, mitoses. SMA is going to be positive. So I already told you the diagnosis. This is your little benign leiomyoma. Doesn't mean anything. Very rarely, however, you might encounter something like this that is a little worse looking. This case was sent to me by Diana Agostini Villai, one of my colleagues at the University of Rochester. And this case is also based seemingly in the muscularis mucosae. Looks smooth muscly. This one's a little more clearly fasciculated, but this one has a lot of atypia. It kind of looks a little bit like that schwannoma, and then you've got focal atypia. The cells are enlarged, funny shaped nuclei, hyperchromatic, but there's no atypia. There's no no necrosis, no mitoses in this example. The largest series that's existing of GI tract leiomyomas encountered 2 of these with nuclear atypia. One of them had prominent mitoses, one did not, but the term they used for this was symplastic leiomyoma of the colon. Rare to see something like this, but it can occur. And again, this is still going to be a small incidental lesion of the muscularis, unlikely to cause any problems, but just showing this to show that in rare cases, the leiomyomas, the small superficial benign ones, can look a little funny. All right, so this patient got a colon resection for this TVA, and then they also had a little incidental finding, which is what I'm here to show you. There's this funny little nodule kind of down in the muscularis propria and the I think this is rectal, so we'll say perirectal fat. It's going on higher power. It's clearly not rounded, well circumscribed. It's infiltrating throughout, but it has that vacuolar artifact that I mentioned in GISTs. If we go in on higher power, it's also very spindly, very GIST looking. And this is in fact positive for c-KIT and DOG1. If you wanted to call this a little GIST, that's fine, but it's not really rounded. It's not presenting quite the way GISTs usually do. So the term that's been given for this is Cajal cell proliferation of the colon. Of course, all GISTs appear to be proliferations of the interstitial cells of Cajal, but this name indicates that it's more kind of proliferative, diffuse, not as well demarcated as your typical GIST, but unlikely to cause problems. I'm just pointing out the name given to this funny looking proliferation. This next patient had a large colon mass that was bleeding and causing obstructive symptoms, so they took it out. You can see how ulcerated it is here, and this was in fact colon. That's not small bowel. This is very, very reactive colon mucosa, showing you that this guy was causing a lot of problems, but that's just because he was big, not because he is intrinsically malignant. This is, as you can tell by all the benign fat, just a lipoma of the colon. Most of these are small, incidental, not going to cause any problems. They can, of course, as seen in this example, grow large and cause obstruction, cause ulceration and bleeding. Rarely, if you see these in a polyp, these also like to live underneath cell-serrated adenomas. So if you get one, just look above it and double check to make sure you're not missing an epithelial proliferation over it. There's a couple different types of lipoma of the colon, and most of them don't really mean anything, but this next one might. This was a small colon polyp, and if we look, we've got that benign fat again, but we can tell that rather than being deep in the wall, it's situated in the lamina propria. It's in the mucosa, it's interdigitating throughout the crypts. So this, we can easily give it the name intramucosal lipoma. And in my experience, most of these are sporadic, don't mean anything, but if you encounter them, you do want to suggest the possibility, not the strong likelihood, but the possibility that this patient could have Cowden syndrome, because it has been reported in patients with Cowden syndrome, along with ganglionomas, other hematromatous polyps. Cowden syndrome can toss up lots of weird things in the colon. Okay, 4 slides to go. We are coming to an end, and then I will answer questions. As I mentioned, vascular lesions in the GI tract are fairly rare overall, but I've got 2 to show you in the colon. This is a colon mass in a patient with a history of prostate cancer, which means he has been radiated in this area, and then he unfortunately developed this nasty post-radiation angiosarcoma. I'm showing this because it's a crazy case. It looks really neat, although it's, of course, quite unfortunate for the patient. And to mention that sporadic angiosarcomas of the GI tract are exceedingly rare. If you encounter them, they're much more likely to be due to, some obvious etiology, such as in this case, radiation. These cells are large, epithelioid, very clearly forming vascular channels. You could do your vascular immunostains, CD31, ERG, whatever your favorite is. That would show that this is positive. So again, rare. Probably you can link it to an etiology if you see it, but this is a radiation-induced angiosarcoma in the colon. This next patient had sort of this irregular area in the colon, and they were immunocompromised, and I've already told you it's a vascular lesion, so you should already have a potential diagnosis in mind. So at low power, we can't really see a discrete mass, but we can kind of tell that the mucosa appears a little expanded, and maybe over here, truly mass forming rather than spindling throughout the crypts. But we can see that this is a spindle proliferation with a lot of extravasated red blood cells, also some slit-like vascular spaces. Not particularly atypical. There's not many ugly cells, not a lot of mitoses or anything, but it's very insidious. You could miss this if you weren't looking very closely, because it's at least partially hiding in the mucosa. In fact, it's still over here too, which is easier to pick out when you know it's there. I told you this is an immunocompromised patient. They have AIDS, and if you did the HHV8 immunostain on this, it would be positive, because this is Kaposi sarcoma of the colon. last but not least, I've got two cases of the appendix, which is one of my favorite little troublemakers in the GI tract. Mesenchymal lesions are very rare in the appendix. So the first one I'm going to show you actually occurred in the abdomen and secondarily enveloped the appendix, but I also think it's a neat slide. Here's what used to be our appendix, and all around it is this low-grade appearing spindle cell proliferation. If we go down to higher power, it's got this prominent but delicate vasculature, very spindling, has a nice school of fish appearance. The cells are actually, this is the muscle. I tricked myself there. This is actually the muscle of the appendix wall, but if we go out, we can see the spindle cells of the proliferation. Here, spindling out, school of fish appearance, all going in the same direction. And if you did a beta-catenin immunostain on this, it would show nuclear positivity in these cells because this is desmoid fibromatosis, secondarily involving the appendix. And this slide serves not only to pull the appendix into this session, but to remind you that mesenchymal tumors involving the abdomen could secondarily involve the GI tract. One thing I wanted to mention, well-diff liposarcs can occur in the esophagus. They're extremely rare in the colon proper. I showed you that lipoma, but you could get retroperitoneal well-diff liposarcomas that then secondarily involve the colon, so you might see it in the colon that way. And then finally, this is a patient with right lower quadrant pain. So of course they got an appendectomy, and most of the appendix has fibrous obliteration. But oh, look at this little guy. What's going on here? Very small, couple millimeters, very spindled, very bland. If you've been paying attention at all, you might be able to guess that this is positive for c-KIT and DOG1. This is an incidental little gist of the appendix to wrap up our session. Gists in the appendix are very rare. In fact, some locations of the GI tract almost never get gists. That includes the esophagus, the appendix, and the colon proper. Not the rectum, they occur in the rectum, but the actual colon rarely gets them. I was fortunate to be part of a large multi-institutional study looking at gists in these rare locations. We submit an abstract on that to USCAP, so fingers crossed that'll be able to be presented in LA next year. Our preliminary findings with what we were able to dig up are that risk stratification based on mitotic count and size does appear to more or less hold for gists in these uncommon locations. Appendix gists were, in our study, uniformly incidental benign like this, although, of course, there's a case report for everything. So if you look, if you search, you can find case reports of large gists of the appendix. So I know it is a little after, we got started a little bit late, but I'm happy to answer any questions that people will have. As I mentioned, if you tweet at me with, or if you post a tweet with the hashtag Mesenchymal Madness, which I'm going to check now, let's see if anyone has any questions, or if I did such a great job that no one has any questions. Any questions that people have? As I mentioned, if you tweet at me with, or if you post a tweet with the hashtag Mesenchymal Madness, which I'm going to check now. I'm not seeing any with the
Dr.
hashtag.
Rahul, I have got one question I can see online. That's from Roberto. So he wanted to know how to differentiate schwannoma from gastrointestinal neural tumor, that is GANT, autonomic tumors.
Sure. So GANT is an older term that isn't really used much anymore. These are basically all called gists now. If you have a spindle cell neoplasm that looks like a gist, stains like a gist with c-KIT and DOG1, even if you get some S100 positivity, or you're feeling fancy and you do EM and it looks kind of neural, you can still lump these under gist. They behave similarly, they're treated similarly. GANT is not really a term that is in common usage anymore.
Right. I think that's all we have. So maybe like people can post questions online and follow the hashtag Mesenchymal Madness. So thanks a lot, Dr. Gonzalez, for this wonderful session. And in fact, I kept the count. So we had 36 cases discussed within this 1 hour time. And thanks so much for your efforts. And Dr. Gonzalez, you will be happy to hear that we had so many viewers from all across the world.
Awesome.
Today we had someone from Moldova for the first time, and we had
Awesome.
viewers from Egypt, UAE, Iraq, Philippines, Algeria, and Peru, Pakistan, Argentina, and so many other places. So thanks everyone, and stay tuned for the next lecture, which is coming up soon. Thank you again. Thanks a
Thank
lot.
you all very much. Have a great day.